Hello, I'm Jan Leichman.
And I'm Muskan Joshi.
Welcome to MedNews Week Conference, where we feature presentations by medicine's global leaders. Today we have an amazing keynote speaker in Dr. Breelyn Wilky. Dr. Wilky is the Director of Sarcoma Medical Oncology, the Director of Translational Sarcoma Research, and the Deputy Associate Director of Clinical Research at the University of Colorado.
In today's presentation, Dr. Wilky provides a comprehensive background of sarcoma diagnostics.
Did you know that Dr. Wilky has designed and led several early phase clinical trials with new targeted agents and immunotherapies against sarcomas?
She is truly an accomplished pioneer in the field of sarcomas.
So let's tune in and learn from this global leader.
So for those of you who don't know, what are sarcomas? Well, sarcomas are actually a group of over 100 different cancers. They're neoplasms that arise from tissues of the mesenchyme, and these include organs like bones, as well as connective tissues like fibroblasts found in tendons, fat, smooth muscle, and so on. And so collectively, this family of neoplasms makes up only 1% of adult cancers and about 15% of pediatric cancers. All of these crazy names are coming from the cell of origin, and they actually can range from what we call well-differentiated sarcomas, which very much resemble the parent cell, all the way to undifferentiated or poorly differentiated sarcomas that have completely lost their way and become quite primitive, looking very much like their original mesenchymal stem cells. These are commonly our undifferentiated sarcomas. They can occur literally anywhere from head to toe, but the most common presentations are a soft tissue mass, so something that's large and growing, like you might see here, or a flank mass. And these are often mistaken for benign entities like lipomas or an injury-related phenomenon like a hematoma. For abdominal tumors, one you can see here, the symptoms are commonly weight gain, bloating, pain, sometimes a blockage of the GI tract, or even bleeding from an involved intestine. So a ton of variability with this very weird and unusual group of cancers. In general, when dealing with newly diagnosed sarcomas, there are several pillars of management that we want to keep in mind. First, get imaging for any mass in the soft tissue that's bigger than a golf ball, or if it's growing or causing pain. The images we use, like ultrasounds and MRIs, often can reveal clues ahead of time that you're dealing with something more aggressive than a typical lipoma or a hematoma. Next, you want to plan a biopsy approach with the surgeon who's ultimately going to remove the mass. A careless biopsy can actually violate tissue planes and cause big problems, risk for recurrence later on. Once you have your biopsy, the next step is getting it in the hands of an expert bone and soft tissue pathologist. The diagnosis can change up to 30% of the time when it's reviewed by an expert, and it's really critical for our treatment decisions, as we'll talk about a lot today. Next, reviewing at a multidisciplinary center. So go to a sarcoma center to come up with a treatment plan or send your patients to a multidisciplinary center. They can still receive treatment locally, but getting everyone's input into optimal management is really critical for the best outcomes. Part of that multidisciplinary workup includes staging scans, which will look for metastatic disease. The most common site for this is the lungs in sarcoma. For truly localized disease, complete surgical resection with wide margins is critical. For borderline resectable or disease that's growing quickly, sometimes our team will consider neoadjuvant treatment or treatment before surgery to control or downstage the disease before attempting a resection. And then finally, we consider radiation and chemotherapy for high-grade or aggressive extremity sarcomas. So I like to talk about treatment really in classifying in three major categories for all those different sarcomas we were talking about. And so we'll talk about this for a minute here. So the first class is our chemosensitive sarcomas. So these tend to be our pediatric subtypes and include diseases like osteosarcomas, Ewing sarcomas, rhabdomyosarcomas, and synovial sarcomas. So for many of these, there's up to a 70% cure rate with standard old school chemotherapy, but it's intense, it's long, and there's a lot of drugs involved. Unfortunately, for patients that developed relapsed or refractory disease, there's been very few advances made in management, and this carries quite a tough prognosis. The other thing is that adults can actually get these pediatric sarcomas. And one thing that's important to note is that the outcomes actually aren't as good in adults. And there's several reasons for this potentially. First of all, adults may not be able to tolerate the intensity or the length of chemotherapy like kids can. There's a question about why these develop in adults to begin with, when they're supposed to be more common in children. So probably a different biology playing a role. And then often our adults are not eligible for pediatric trials due to age limits and so on. So they're challenging to deal with in the adult population. The next group of sarcomas that we think about are chemo-resistant. So we never use traditional chemotherapy for many of these types. Fortunately, with some of the advances in modern molecular technology, even the rarest of the rare subtypes of sarcoma, we're finding molecular alterations or genetic changes that are conserved and often druggable with new therapies. These tend to be chemotherapy pills or targeted therapies that block particular molecular signaling pathways. So just to show you a few examples, several sarcomas are closely associated with something called vascular growth factor or blood vessel pathways, so VEGF-related disease. These can respond to VEGF targeting chemotherapy pills like solitary fibrous tumors and alveolar soft part sarcoma. Chondrosarcomas, these are cartilage cancers. They often have IDH1 or 2 mutations, and we can take advantage of drugs that are recently approved for other cancers like leukemia that have IDH mutations. Pecomas, this is an extremely rare type of sarcomas that have alterations in a pathway called mTOR, and we actually just approved a brand new drug specifically for this tiny group of sarcomas called nab-sirolimus. Gastrointestinal stromal tumors, these are actually much more common, and you'll actually see these on a regular basis. So these are driven in the vast majority of the time by activating mutations in KIT and PDGFR. And so there's several chemotherapy pills to target these types of sarcomas, including 2 recently approved drugs, ripretinib, approved for 4th-line treatment of GIST, and then avapritinib, which is approved for one very specific resistant type of PDGFR GIST that's resistant to imatinib. And then finally, these are 2 benign sarcomas. However, they're locally aggressive and cause a tremendous number of problems. So tenosynovial giant cell tumor is a disease of joints, and it's driven by a protein called CSF1. And we just approved a drug blocking CSF1 called pexidartinib. And then giant cell tumor of bone responds very well to denosumab, which blocks RANK ligand. So this sort of gives you a flavor for how we can customize treatment and why it's so important to get the diagnosis right, knowing any particular druggable genetic alterations. And then finally, the third class, the others. So unfortunately, this is what we most commonly see in our clinic. These are our common adult subtypes like pleomorphic sarcomas, liposarcomas, and so on. Unfortunately, here there's limited activity of cytotoxic chemotherapy as well as targeted therapies. So what I'm showing here on the right is a list of chemotherapy drugs that have been approved or that are commonly used in sarcomas. And unfortunately, over the last 40 years to date, no drug or combination of drugs has improved overall survival for metastatic sarcomas like these above doxorubicin alone. But even if you look at doxorubicin and any of these drugs, the overall survival is still only 12 to 18 months or so. So we need to do better, and we need to find other treatments. The progression-free survival, which is how long the disease is stable with any of these drugs, ranges anywhere from 2 to 6 months. So we still have a lot of work to do. Targeted therapies, again, we recently approved tazemetostat for epithelioid sarcomas, which is great. And there's many ongoing trials looking at CDK4 inhibitors for liposarcomas. But again, these are palliative treatments. We're not getting cures here for this group of diseases. So what about immunotherapy? So if any of you know this, back in the day, Coley's toxins, which are basically bacterial infections, Dr. Coley used these toxins to treat cancers, and sarcomas were among the tumors that regressed or went away with those bacterial toxins way back in the 1890s. So there's been this long time thought that potentially sarcomas could be recognized and killed off by the immune system. There's a couple of other interesting facts about sarcomas. So sarcomas that have spread to only a few locations can sometimes be cured if you resect all of the sites of disease, even though you know there's got to be seeds or residual deposits of sarcoma somewhere in there. So it's tempting to imagine that the immune system is able to hold those little seeds stable if you can get rid of the bigger foci of disease. And then finally, there's variability in the progression of disease. So I just showed you these horrible statistics that people only live for 12 to 18 months with metastatic sarcoma. But if you talk to doctors who take care of these patients, or you talk to patients, there are people out there who can live with very smoldering, slow-growing disease for years. And so the question is, does the immune system play a role in helping to hold back some of the growth of this cancer? So as we start to think about new immunotherapies, which have clearly changed the landscape of cancer across the board, it's important to keep in mind a few things. So many of you have probably seen this figure a million times, but I'm just going to go through it again because it's important to understand how we can use immunotherapy for sarcoma in particular. So in order to get our immune system to kill sarcoma or any cancer, there has to be something about the cancer cells that's recognized by our immune system as being foreign or damaged, and these are called antigens. If your immune system can recognize the cancer as being bad, that's usually done by our surveillance cells or our antigen-presenting cells, macrophages or dendritic cells, who then go on to teach our more educated immune cells, our T cells, to prime, turn on, activate, expand, and then ultimately we direct them to traffic and migrate to the tumor and get into the tumor beds where they can actually start to kill off the cancer cells. So they run into a lot of problems along the way here, especially in sarcomas, which are huge tumors. They're often very poorly vascularized, so there's not good blood flow. This creates regions of hypoxia, which changes energy availability. It makes it very hard for our T cells to live and be active and be healthy. So there's a lot of barriers to get through, particularly in sarcomas, to get to this last step where the tumor cell and the T cell are face to face and the T cell can actually kill off the cancer cell. So where does immunotherapy come in? Well, we can work at multiple steps in this process. The most famous place is at the very end. So PD-1 and PD-L1 are the targets for these new immunodrugs called checkpoint inhibitors. And the idea here is these drugs block that don't eat me signal that the cancer uses to shut off the T cell at the very last point. So we've also in sarcoma begun looking at other areas. So many of those TKIs, those chemotherapy pills I was showing you, actually work in the microenvironment to make it a more favorable or hospitable place for the immune cells to live and thrive. So we can try to improve that. And then the other checkpoint inhibitor is CTLA-4, which helps to boost that education process by the antigen-presenting cells to our T cells. And it also helps to encourage these guys to do their job more effectively, not suppress the immune response, but activate and promote the immune response. So do checkpoint inhibitors work in sarcomas? Well, the answer is yes. So this is the patient that really changed my whole career towards focusing on trying to figure out how to make immunotherapy work for all sarcoma patients. So this lady's 60 years old. She has cutaneous angiosarcoma, or a blood vessel cancer on her face that you can see here. And I had previously treated her with over a dozen different therapies during my practice. So we had done a very aggressive surgery, we had done radiation. I treated her with all those chemotherapy drugs that I showed you, targeted therapies, even clinical trials, with continued progression and growth of her disease. And it was very upsetting and damaging locally by her face. So the next thing we did was put her on a phase 1 clinical trial of an anti-CTLA-4 inhibitor, very similar to ipilimumab, the approved one. And she went on at dose level 1, 0.1 milligram per kilogram dose, which is 10-fold less than the lowest dose of ipilimumab that's commonly used. She remained on this treatment for 18 months. She got a radiographic complete response. Here's the tumor here, and you can see on this follow-up that it's completely gone. And then we actually biopsied her as well. And when we did this, we proved there was no residual cancer left behind. So a pathologic complete response as well. She remains cured to this day, 5 years later. So clearly immune therapy can work for sarcomas. And since this patient, there have been multiple trials and multiple reports of cutaneous angiosarcomas being susceptible to checkpoint inhibitor mediated killing. So what about other types of sarcomas? So let's take a second and kind of look at the first major clinical trial for sarcomas and checkpoint inhibitors, which is the SARC-028 study of pembrolizumab monotherapy. So this is an open label phase 2 study run in 2 parallel cohorts for bone sarcomas shown here, and then for 4 different kinds of soft tissue sarcomas, and the types are shown up here. So unfortunately for bone sarcomas, we didn't see much in the way of responses. The response rate was only 5%. There's problems with measuring bone tumors in general. They often don't shrink, but still there were definitely patients not doing well with therapy. On the other hand, for soft tissue sarcomas, we saw multiple responses for a rate of 18%. These tended to be in patients with the pleomorphic sarcoma subtype, as well as liposarcomas or fat sarcomas. Once these were expanded, the pleomorphic sarcomas carried about a 23% response rate, and liposarcoma was about 10%. So this was very exciting and really started the movement to start understanding immune therapy for sarcomas. So this is a very busy chart, but basically this is what we've done since that trial. And so we've started trying to do combinations with PD-1 directed checkpoint inhibitors to improve the outcomes over 20%. And so many of these targets are the things I was showing you on that figure. So combinations with CTLA-4 drugs shown in purple, combinations to combat suppressive macrophages, making our antigen presenting cells work more for us, drugs that target the microenvironment, axitinib and sunitinib, and then chemotherapy, which we'll talk about a lot here in a few slides. The point of this, though, is if you look at these response rates across all these different combinations, with the exceptions of a couple very strong signals for angiosarcomas and a disease called alveolar soft part sarcoma, again, we're left with a 20% response rate for the most part. And again, there's some progress being made with chemo, and I'll show you more about that, but just 20% seem to be our ceiling for sarcomas, even with all of these different combinations. Why are we stuck at 20%? Well, it's important to remember what I showed you. All of our efforts to use checkpoint protein inhibitors assume that we have successfully generated a population of tumor-specific T cells that are available to kill the cancer. So my argument is that I think the majority of the problem lies at the very beginning. I think in general, our immune system has a very hard time recognizing sarcoma. So if there's no immunogenicity, there's not going to be any tumor T cells. And then no matter what you use, whether it's the microenvironment or certainly checkpoint blockade, you're still not going to get responses if your immune system never realized that the cancer was a threat. So why are these so poorly immunogenic? Well, a couple of possibilities are that there are very few tumor-specific antigens to recognize, or that the ones that are there are very crummy. They don't do a good job of triggering our immune system's recognition. The other problem is there's a protein called MHC1 that is critical for the antigen presentation process. And I'll show you some data that many times this is silenced. It's a way for the cancer to avoid having its antigens displayed to the immune system. So overall, I think that a lot of our work needs to be done earlier on in the process. So what about tumor mutational burden? So basically, this is a measure of how many mistakes or how many abnormal proteins are associated with a particular cancer. And we know that tumor mutational burden has been a very helpful marker of response for immunotherapy and other types of cancers. Overall, TMB is low in sarcomas compared to other cancers like melanoma or lung cancer. But in this paper, Dr. Rozic and his colleagues showed that even among sarcomas, and there's several subtypes shown here, there is still a subset that has a higher mutational burden. And interestingly, these are the subtypes that tended to respond to the pembrolizumab monotherapy, UPS and liposarcoma. They tended to have a higher degree of mutational burden. However, leiomyosarcomas shown here also had similar mutational burden, and they have almost a 0% response rate with pembrolizumab by itself. So the mutational burden here can't be the whole story. Here's that data about that MHC class 1 protein I was talking about. So again, it's a critical component to present antigens to the surface and to the immune cells. Now, you can see here across a bunch of different cancer types that many cancers are decreased expression of MHC class 1, greater than 50% of cases. And if you focus on the sarcoma group shown right here, this is 160 patient samples, and 3 of the 4 papers reported more than 50% of sarcomas missing or having decreased expression of that critical antigen presenting machinery. So what does this do to the rest of our immune system? So this is a famous paper that was published in 2020, where the authors basically collected all of the genetic data deposited in several publicly available databases, and they looked at the immune-related genes and created signatures across about 230 sarcomas of 3 subtypes, the big 3 that we've been talking about: the liposarcomas, the UPS that respond to immunotherapy, and then the leiomyosarcomas. And so they clustered the expression together, and they found that, again, interestingly, just under 20% of sarcomas have a very high expression of immune-related signatures. And so these include particular immune cell types, the killer T cells that we've been talking about. It also includes class 1 MHC expression. So again, very red or high expression of MHC was seen in this subset. The high immune class also had something called tertiary lymphoid structures, which are essentially these clusters of immune cells found within the sarcoma deposits that represent a very well organized and active immune response going on within the tumor. And then they also found this group had very high expression of various checkpoint proteins. They went on then to look at that signature, that immune high class signature, and they applied that to all of the patients who were treated with pembrolizumab in SARC-028. The immune high subset is shown in red, and you can see by this waterfall plot of the patients and their responses that, again, more patients with immune high tended to respond to pembrolizumab monotherapy, and they also had better progression-free survival. Now, it's not perfect. You can see various tumors scattered with high expression that did not respond, and there's a few with either medium or low response that did go on to have a response to pembro monotherapy. But this is still quite compelling. So those of you who know immunotherapy, you know about PD-L1 expression on the tumor. So this is the don't eat me signal. So in other types of cancer, if the tumor cells have PD-L1, that predicts response to checkpoint inhibitors, to PD-1 inhibitors. So unfortunately, in sarcoma, that's not a sufficient biomarker. So this study that I'm just mentioning here pooled the analysis of 3 trials reporting baseline PD-L1 expression in sarcoma. Overall, only about 13.6% of sarcomas have PD-L1 at all. Of those 21 patients that were treated on trials, the response rate was about 30% with various combinations. In the PD-L1 negative sarcomas, 133 patients, there was a 7% response rate. So that being said, there's still 70% of PD-L1 positive patients who do not respond. And so all of this is basically telling us that PD-L1 is helpful when it's present, but it's not a guarantee. And we need to be looking at other potential biomarkers, including the presence of those lymphocytes. Now, this has looked promising in other studies, but many of these have very limited what we call phenotyping or classification of those immune cells, because they could be activated, they could be suppressive, we're just not sure. And that may explain some of the confusing data that's come out of these analyses. So 20% is great, but what do we do about the other 80% of sarcomas? How can we improve the activity of immune therapy and make it work for patients with immune cold sarcomas or low expression of immune-related genes? So I think, again, targeting tumor immunogenicity. How can we improve the tumor immunogenicity for those tumors? The ideas are chemotherapy, radiation, and cytokine therapy actually help to boost the immune recognition process and make the cancers appear more foreign. Additionally, you could bypass this whole step and go straight to adoptive cellular therapies. So these are treatments that provide a very large population of tumor-specific T cells to the patient if you know the target that is on the tumor cell that you're trying to go after. And so I'm going to walk you through the future advances and what we've been working on in both of these areas to try to make this better. I'll describe to have very potent stimulatory effects on our immune system. And one of the best studied drugs to show this is doxorubicin, our friend in sarcoma for the last 40 years. So in various mouse models and patient models, treatment with doxorubicin leads to production of danger signals, things called danger-associated molecular patterns or pathogen-associated molecular patterns. These are signals that are very similar to what happens when a cell is infected by a virus, and is a very potent stimulus for your immune system to go in, recognize the area as a problem, and start the immune cascade. DNA damage resulting from doxorubicin also triggers another pathway critical to the immune response, which is CGAS and STING. All of this has been shown. Our other chemotherapy drugs in sarcomas also have immune-related effects. Gemcitabine can suppress myeloid-derived suppressor cells, which tend to shut down immune responses. Trabectedin can decrease the suppression by cytokines and macrophages. And then eribulin has profound effects on blood vessel development within tumors or angiogenesis. And so based on this, this is the new wave. So there are multiple clinical trials in sarcoma going on now to combine chemotherapy with immune therapy with our checkpoint inhibitors. And so I'm going to show you a few of the studies that have published or presented data on this approach. This is the first study. So this was published by Seth Pollack out of the University of Washington, the Hutch Cancer Center. So they treated 37 patients with advanced or metastatic soft tissue sarcomas with doxorubicin plus pembrolizumab. And basically you can see the waterfall plot here that the response rate was about 19%. That being said, the progression-free survival, or how long patients remained stable, was 8.1 months. And just to remind you, our previous historical data for doxorubicin is fairly similar. So 18% response rate and a progression-free survival of 6 to 7 months. But I think if you look at these plots, the spider plots, you can see that several patients are having long-term durable control of their disease with this approach. This is in days. So we're looking at 2-3 years out on treatment. Quite impressive. And again, for a subset of patients, they're clearly benefiting from this therapy. This trial is a little tricky because almost half of the patients were other subtypes, and there's a question of whether there was more slow growth or different biology that may have favored this, but in general, this was really exciting and promising. We got even more excited when the second trial came out from Mike Livingston out in North Carolina, and here they treated 28 patients, again with doxorubicin and pembro, and basically showed a response rate of 36.7%, which is definitely better than what we've seen historically with doxorubicin monotherapy. Now, this trial included more of our favorites, so more of the common types of sarcomas that have previously been studied. Leiomyosarcoma, interestingly, had a 40% response rate out of 10 patients. So compared to pembro alone, where we rarely see sarcomas, or we rarely see leiomyosarcomas responding, this was pretty exciting to see. And then 100%, all 3 of the UPS patients did respond as well. The progression-free survival for this trial was 6.9 months, so a little bit less than Dr. Pollack's study. And then the progression-free rate at 6 months was about 52%. So again, promising signals, but still we have more work to do. It's not helping everyone, but definitely looking promising. So now I'll just plug my trial. So this trial is a combination of doxorubicin, CTLA-4 inhibitor, zalifrelimab, and a PD-1 inhibitor, balstilimab. And so we are currently enrolling patients on this study, which will have 28 evaluable patients with advanced or metastatic soft tissue sarcomas. And basically what we're doing here is patients get 4 doses of the CTLA-4 inhibitor, 6 cycles of chemo, and then they're able to stay on PD-1 maintenance after completion of their chemotherapy. And so we've completed the first stage of this study. We're very excited about it and hoping to have data to present later this fall. Importantly, we are actually looking at correlative studies, so tumor biopsies and blood along with this to try to understand why patients are responding or not responding. So overall, I think the thing with chemotherapy is that, we're really so far have only seen trials where patients are treated with both agents, and to really understand whether there's a significant difference by adding immune therapy with chemotherapy, we need to start doing randomized clinical trials where patients get either chemo alone versus the whole combination to prove that this makes sense. I'll just show you this one other trial. So again, with the CTLA-4 and the PD-1 plus chemotherapy with trabectedin, this study was presented at ASCO, not yet published, but it was larger. So 79 patients treated with the triplet therapy. Response rate was again 20%. Progression-free survival was 6.7 months, but you can see that the disease control rate, which is stable disease plus responses, was 85%. So pretty exciting here looking at this trial as well. What about radiation? So radiation also is a potent stimulus to our immune system. Now it's tricky in trials of metastatic cancer because it's always hard to tell, well, what is actually benefiting from the radiation alone versus what's benefiting from the immune therapy alone. So I just want to highlight this trial that's ongoing now that is super important for the field, and I think will really tell us a lot about how this is working together. It's a randomized phase 2 trial for patients with localized UPS or liposarcoma, and they either get the standard of care, which is radiation prior to surgery for removal of their sarcoma, or they get radiation with pembrolizumab followed by surgery, and then more pembrolizumab after completing resection. Again, great correlatives, biopsies, tissue analysis, blood built into this study. So we're really excited to see how this impacts progression-free survival, development of metastatic disease later on after their surgery, all of these things. So this is definitely a trial to keep an eye on. So switching gears a little bit, let's talk about adoptive cellular therapies. So adoptive cellular therapies basically involve collecting a patient's own immune cells and then engineering them in the lab with either a T cell receptor or a CAR receptor specific for a particular antigen or particular protein associated with the tumor. The T cell receptor therapy requires that we have our partner MHC class 1, and the MHC has to present that antigen. So this is some of the limitations for this type of treatment, is that the T cell receptors are developed for certain types of MHC1, and similar to blood types, we all have different HLA or MHC1 types. So this is one thing to keep in mind. However, the benefits of this approach are that you can look for intracellular proteins because everything's being presented and sent to the surface. On the other hand, CAR T cells require that it be a cell surface protein that it's designed to go after and bind to. So this is a little bit trickier for solid tumors and has been an ongoing issue in the field, but certainly CAR T cells have worked tremendously well for other types of cancer like leukemias. So what about sarcomas? Where are we with adoptive cellular therapies? Well, we need more targets, that's for sure. But the two targets that have been most promising are what we call cancer testis antigens. The protein NY-ESO-1 as well as MAGE-A4 are expressed in 70 to 80% of synovial sarcomas and myxoid round cell liposarcomas. There are other types of sarcomas that express this as well, but overall it's a lower percentage. So these trials are currently in late stages for registration. So we're very optimistic to see the final data and hopefully seeing this gets approved for use soon for these subtypes of sarcomas. And I'll show you these data here in a second. CAR Ts are a little bit earlier on for sarcoma. There was a phase 1 trial completed with a HER2 CAR T cell, which actually showed better toxicity than older variations of HER2 CAR Ts where there was cardiotoxicity in the past. Again, primarily for pediatric sarcoma subtypes in this trial, but very interesting. And then there are 3 ongoing phase 1s that just opened up looking at B7H3 CARs, GD2, and EGFR CAR Ts for pediatric sarcomas primarily. And so really exciting to see the results of these trials over the next few years. So here's the data for the engineered T cell receptor therapies for synovial sarcomas. Again, waterfall plots shown here on the left for the NY-ESO or the lete-cel therapy, and then MAGE-A4 for SPEAR T cells on the right. Again, these are HLA-A*02 restricted, so only about 30 to 40% of patients will have the right tissue type to participate in these trials. But you can see from the waterfall plots that they're quite effective. Response rates are 44 to 50% depending on the agent. And if they achieve a response, the median duration of the response is about 30 weeks. So clearly exciting, lots to learn here. And unfortunately, we just need more sarcomas to actually have these targets or come up with targets that are more expressed on other types so that we can start exploring these therapies more broadly. So where do we go from here? Well, this is an outdated graph from 2018 that just shows the landscape of all the different agents and combinations that are being explored with checkpoint inhibitors in cancer. This is crazy. And with our rare diseases really, and the heterogeneity, we're never going to be able to test all of these different possibilities in our sarcoma patients as much as we would love to. So what we need to do is we need to work smarter. We need to refine our ability to classify our sarcomas, look for biomarkers and immune signatures to select combination therapies more likely to work for individual sarcoma patients. And I think the way we're going to have to do this and to really move the needle, given our barriers, is to find combinations or other ways to hit multiple steps in that immune cascade without creating too much toxicity. So how do we do this? We need to model it in the lab, and then we need to study the patients who are treated on trials. Every single thing we can, we have to learn from every patient. And as a community, we need to work together to pool our data from all of these different ongoing clinical trials and really try to start making sense of who's responding, who's not, what are the mechanisms of resistance and success, and how these treatments actually working when they do. So in summary, I hope over today I've convinced you that even though we're a very heterogeneous group of sarcoma cancers, and these are very rare collectively, we are moving the needle. We're doing this because now we understand the molecular drivers and the genetic alterations better in these heterogeneous diseases. And we're working together to conduct clinical trials focused on particular subtypes. And we have to do this with multi-center collaboration, but it's led to multiple new drugs being approved for smaller subtypes of sarcomas over the past several years. And again, we need to continue to work to customize our treatments based on biology and the mechanism, what's really driving individual patients' tumor growth. I hope I've convinced you that immunotherapy has great promise. When it works, it can cure sarcomas. And all it takes is to see a patient who you never would have cured with chemotherapy. When their disease melts away, you would become a believer. To do this though, and to really make it work for everyone, we've got to deal with this immunologic blandness. There's nothing foreign about sarcomas to be recognized. We have to find a way to trick our immune cells into figuring out the game. To do this, we need to improve our understanding of the immune microenvironment. We unfortunately don't get to rely on PD-L1 to signal the patient's likely to respond. And it's most important, particularly at this phase, to get patients with sarcoma to immunotherapy clinical trials early. If we wait until the disease is advanced, rapidly progressing, and patients are sick, there's simply not enough time for the immune system to learn what it needs to do and to catch up. We run out of time. And so I think that's a critical component of how we're treating sarcomas now. Is many of our chemotherapy clinical trials are early lines, first or second line therapies, even third line. Get patients to trials early so that they can have the opportunity to benefit from these novel approaches.